female presented with cough and dyspnea. The patient had history of chest infection since 2 years old. The patient had done chest X-ray. There was a hyperlucency in the left side.
Axial coronal section CT scan of the chest showing reduced lung volume of the left-sided hemothorax and paraseptal emphysema and cystic bronchiectasis changes. بس دكتور بعد نشوف الأكزيال.
نعم.
No mass seen, no lymphadenopathy or pleural fusion.
هذا الابنورماليتي كلها بالليفت سايد دكتورة إيمان.
نعم. And more translucent than the right side blank.
نعم بالإكس-راي. نعم.
العفو بهايبو دنس مرتين
إذا قلت أكو نيوموثوراكس أكو سيستيك برونكيكتسيس أكو لوس أوف فوليوم حتى من أكو شيفتنج ميدياستاينال شيفت slightly to the left side. زين هاي الفيتشرز in a boy old 12-year-old.
نعم.
بس شوي خلي أريد أشوف البروميناري ريزلتس.
الكورونا أوضح دكتور طلع لك إياها.
أوكي. Thick of the bronchial wall.
بعد شو السيدي على هيستوري مال؟
يعني هو قال بالهيستوري أكو history of infection, recurrent infection.
بل. شنو الكوز مال هالبرونكيكتسيس هذا؟ إيمان؟
يعني thickening of مال إذا recurrent infection مال bronchitis obliterans لأن أكو thick wall of the bronchus.
بعد شو تخليني ببالي؟
يعني إذا نخلي congenital lobar emphysema بس هي يعني ما تجي هيجي وياها features مال bronchitic changes و paraseptal emphysema يعني تجي أكثر.
زين. شنو الكوزز مال برونكيكتسيس؟ هي برونكيكتسيس يعني اكو سبوراديك، اكو سيندروماتيك، اكو مو صحيح؟
نعم.
شنو اللي ببالك يعني 12 سنة شو اسمه؟
هو إذا 12 سنة bronchitis obliterans the most common cause يعني بهيج age.
بعد شي سيندروماتيك كذا.
إذا dyskinesia أو همين تجي young age. الهارت in normal site.
زين.
ممكن الماكلويد syndrome or Swyer James syndrome.
ماكلويد انفيزيما مو يصير برونكيكتسيس.
نعم ما يجي يا bronchiectasis changes.
يا سيندروم يجي يا برونكيكتسيس.
الكارتيجنر بس الهارت on the left side.
ذاك شو يصير؟ ديكستروكارديا.
dextrocardia or هو البيشنت يجي sinusitis bronchiectasis or يعني features of cystic fibrosis.
مروان مسوي له
نعم.
للساينسز هذا؟
شلون عفوا أستاذ؟
مسوي
لا
له
لا أستاذ، لا
ساينسز؟
لا 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 عفوا أستاذ، لأنه نون كيس هو كان.
بس هذا شو تخلين الكوز يعني؟
يعني first differential bronchiolitis obliterans.
برونكيولايتس اوبليترانس. عادة تصير يونيلاترال.
نعم.
وما كومبليكيت باي انفيزيما.
أي.
شو يسوي له هذا؟
يعني medical treatment.
like this advanced left-sided bronchiectasis almost اللنج هذا ماكو هذا يعني very recurrent chest infection يعني.
ممكن يسوي له resection. لا
يعني إذا
أو lobotomy.
إيه طبعا إذا لوب عنده فك بس هذا كأنه ما ديفيوز ليفت لنج. أوكي شكرا إيمان. دكتور مروان احكي لنا على الكيس ابني.
نعم أستاذ. 12 years old female present with recurrent chest infection since 2 years old. Her emerged presented with cough and dyspnea. The patient he known case of Swyer James McLeod syndrome. The patient had a smaller lung volume on the left compared to the right side, with reduced lung attenuation, reduced pulmonary vessel caliber, bronchiectasis, and bronchial wall thickening. There is emphysematous change involving the whole lung. The patient on the right lung has a little fibrotic change and mosaic attenuation of the lung، اللي هي واحدة من الكومبليكيشن يعني. البيشنت جتي حاليا على مود اكو كومبليكيشن مال نيو نيمونيا اور نو. انتقل للتوك أستاذ لو.
بس هذا التشخيص مالته شنو صار؟
سوير جيمس ماكلاود سيندروم أستاذ.
اوكي يلا نروح على التوك.
السلام عليكم. Swyer James syndrome, also known as Swyer James McLeod syndrome and Britt syndrome, is a rare lung condition that manifests as unilateral hemothorax lucency as a result of post-infectious obliterative bronchiolitis. Initially, Swyer James McLeod syndrome was believed to be congenital in origin, secondary to inborn hypoplasia of the pulmonary artery. Although its definitive cause remains uncertain, it is now widely accepted to be a rare complication of childhood respiratory infections, most commonly bronchiolitis obliterans or pneumonitis. The causative agents implicate recurrent pulmonary infections include viruses such as measles, respiratory syncytial virus, influenza A, adenovirus type 3, 7, and 21, or bacteria such as Bordetella pertussis, Mycobacterium TB, or Mycoplasma pneumoniae. Bronchiolitis obliterans describe a clinical syndrome of a small airway obstruction that is irreversible to bronchodilators. This is triggered by injury to bronchiolar epithelium and possibly the adjacent alveoli. This damage, which occurs during early childhood, hinders the normal development of alveolar ducts. The injury may be caused by a range of factors, with respiratory infections playing most role in the syndrome. While complete recovery is possible, the repair process may lead to a surplus proliferation of granulation tissue, resulting in narrowing or complete obliteration of the small airway. Unilateral or recurrent small airway obstruction involving terminal bronchi and bronchioles occurring early in life trigger inflammatory response, which lead to development of submucosal fibrosis. The resulting luminal irregularity further contribute to airway occlusion, becoming more permanent. This in turn causes alveolar air trapping, eventually resulting in emphysema. Alveolar wall destruction lead to loss of elastic recoil, causing airway collapse during exhalation and air trapping. Therefore, the typical appearance of unilateral hyperlucency can be found on radiograph. The other more important factor responsible for the radiographic hyperlucency of a single hemothorax is the reduction of the pulmonary blood flow. Fibrosis of the interalveolar septi lead to obstruction of the pulmonary capillary bed and reduce the blood flow to the major pulmonary artery branches. Moreover, hyperinflation of the alveoli, as seen in emphysema, create additional mechanical resistance to blood flow through the capillary beds. Since this process occurs early in life, arterial development is thwarted, resulting in hypoplastic pulmonary vasculature. Additionally, reduced ventilation of the diseased lung or segment also lead to compensatory vasoconstriction of the pulmonary vessels, leading to functional restriction of the arterial flow, which contribute further to the radiographic hyperlucency. Functional hypoplasia of the bronchial vasculature may impair the growth of the affected lung, leading to lung that's either small or normal in size. In some patients with Swyer-James syndrome, bronchiectasis may develop proximal to the bronchiolitis obliterans and is likely to sequelae of the chronic infection. On the radiographic feature, the plain radiograph, the first-line investigation is X-ray of PHS radiograph, which will reveal reduced bronchovascular marking, as you see on the left side, and small hilar shadow and hyperlucency of the diseased segment or loop. These findings are more prominent on expiration when the diaphragm on the affected side rises. To a lesser extent, the lung deflates only partially, demonstrating a degree of air trapping. On expiration, the difference in transradiancy becomes even more obvious as the normal lung deflate and become more opaque. The mediastinum may also shift to the affected side, but will move toward the normal side on the expiration. On the CT scan, the CT of the chest is usually the modality of choice used to assess the extent and distribution of the disease. It may demonstrate emphysema, bully, bronchiectasis, atelectasis, and scarring. CT chest is much more sensitive than plain radiograph, as it is often demonstrate a bilateral lung involvement, and the change may be inhomogeneous. The scanning protocol should also include some expiratory slices to demonstrate air trapping clearly. Bronchiectasis is present in about 30% of the patient with the syndrome, may be either cylindrical or saccular. Distinguishing between the two types is essential, as it predicts the clinical course and the prognosis. Patients with saccular type bronchiectasis tend to suffer from more severe exacerbation and have poorer outcome. If bronchiectasis is suspected based on the clinical feature, a high-resolution CT of the chest is advised to ensure the diagnosis is not missed using conventional CT and to allow correct differentiation. On ventilation and perfusion scan may reveal a unilateral mashed ventilation and perfusion defect of diseased area. Some advocate it is first-line investigation following the chest radiograph in the evaluation of the patient with the Swyer-James syndrome. CT pulmonary angiography is not essential, but would demonstrate a hypoplasia of the pulmonary vasculature in the affected lung or segment. The MRI angiography may also show a pulmonary artery with diminished vascularity in the periphery. The diagnostic criteria of this syndrome require one of the following: either unilateral loss of the lung volume with hyperlucency as demonstrated by the chest X-ray, or unilateral reduction in the vascularity on the CT of the chest, or unilateral loss perfusion on technetium-99 lung scan. Treatment and prognosis. Treatment is conservative and preventative, focused primarily on the controlling pulmonary infections. Inhaled corticosteroid may have limited role in treatment. Surgical intervention is reserved for patient with recurrent pulmonary infection, patient who fail to respond, patient whose symptoms are not adequately controlled with optimal medical management. Surgical options include pneumonectomy or lung volume reduction surgery like lobectomy or segmentectomy. This has previously been achieved without significant morbidity, but with a dramatic improvement of symptom and respiratory function. Lung volume reduction surgery has been particularly successful in patients with significant hyperinflation secondary to emphysema, as it may exert a favorable effect in the mechanics of the airway, diaphragm, and chest wall. On differential diagnosis, the congenital lobar emphysema is a developmental condition of the lower respiratory tract characterized by alveolar overdistension within one or multiple pulmonary lobules. It is believed to be a result from many different abnormalities of the bronchopulmonary development. A quarter cases are caused by obstruction of the developing airway in early life. This leads to air trapping and progressive terminal airway hyperinflation as more air enters the affected lung segment during the expiration than leave during expiration, so-called ball valve mechanism. Characteristic finding on chest X-ray: distension of the affected loop, mediastinal shift with compression and atelectasis on the contralateral lung axis, flattened diaphragm due to hyperinflation. A high differential كل اللي هي مثلنا الhyperlucency of the affected side. The other differential is localized pulmonary interstitial emphysema. It is similar to the CLA, but develop a complication of mechanical ventilation at high airway pressure in infant. It may be caused by obstruction of larger airway by a foreign body, mass, bronchogenic cyst, or bronchopulmonary sequestration, congenital pulmonary airway malformation, or congenital diaphragmatic hernia, or pulmonary artery sling, or airway collapse, which may occur if the airway is floppy, like congenital bronchial atresia. The other differential is pulmonary development abnormality like agenesis, hypoplasia, aplasia, where a loop or lung or bronchi vasculature fail to develop completely or partially. This leads to unilateral hyperexpansion and radiographic appearance of hyperlucency, closely resembling that seen in Swyer-James-McLeod syndrome. Poland syndrome, on the other hand, is a spectrum of congenital chest wall anomalies of unclear etiology, comprising a hypo or agenesis of the anterior chest wall muscles, pectoralis major, pectoralis minor, latissimus dorsi, serratus anterior, and intercostal muscles, hypoplasia or absence of the ipsilateral ribs, and hypoplasia or aplasia of the mammillary tissue. This gives radiographic appearance of unilateral hyperlucent hemothorax, which may mimic Swyer-James-McLeod syndrome. Swyer-James-McLeod syndrome may be mistaken for pneumothorax. In severe cases with reduced breath sound and hyperlucency of the chest radiograph, careful examination of the imaging as well as clinical assessment allow for correct diagnosis to be made and prevent unnecessary chest tube placement. Reference. Thank you.
شكرا جزيلا دكتور مروان. إذا
عفوا.
كيس